Next speaker is Laura Mauri. She was already introduced yesterday. I just would say that she's a leader in interventional cardiology and an expert in designing clinical trials. Laura, whenever you want.
Thank you. I want to start really by thanking the organizers of the conference for the opportunity to join you. This is my first year at the conference, and I know many of the speakers have been here many times over the years, and it's been really wonderful hospitality, but the level of the conversation is at such a high level that I've really enjoyed the interaction, both with the speakers, but also with the cases that were presented yesterday. And it's really on the level of the highest level of any conference that I attend, and I've enjoyed it immensely. So thank you very much for the opportunity. I'm going to speak to you today about innovation in percutaneous coronary intervention. And I could give you a list of devices, and I will talk a little bit about specific devices. But I think that the real challenge for innovation going forward is not just about bringing new devices into the cardiac cath lab, but it's really about providing better information so that we can guide therapy in a much more targeted way. And I think that this fits in very well with the sort of challenge that we're faced with that our first speaker, Dr. Rademacher, introduced, to really challenge and question not just the availability of technology, but the real benefit to society. So we know that if we measure under a conventional endpoint that percutaneous coronary intervention has really improved dramatically over the past 20 years. If we start with the era of angioplasty, at that time point we expected to see very high levels of restenosis, but also periprocedural myocardial infarction. And both the devices and the drugs that we've used have really evolved. And now we expect to have very low rates of complications. But I think this really raises the bar for what we are looking for going forward, to not just look at these simple complication rates. We're no longer limited by restenosis, which drove our development of devices in the past, but now need to look at more refined decision-making. So the innovation in PCI will not just come from drugs and devices, but from evaluation of treatment strategies going forward. And this is really where we cannot be led only by industry trials, but also need to have important clinical input into deciding how best to treat our patients. So if you look at 2012, where we stand right now, we have very modern stents that are available, have great results with low acute complication rates, and also very stable safety going forward for the lesions that we treat. We have advanced dual antiplatelet therapy to broaden the therapeutic window so that we can treat many patients with high potency, but also relatively safe platelet inhibition. At the same time, we've seen a decline in the total number of coronary interventions. If we look within the United States, the peak has already passed in terms of the number of coronary interventions performed. And probably this is a good thing. This is a measure of the performance of better primary prevention, and also of the recognition that not all coronary stenoses need to be treated with a coronary stent. There's also more selective use of drug-eluting stents than what we probably saw about 5 to 8 years ago, in that we don't necessarily use a drug-eluting stent in every patient. It may be applicable in the majority of patients, but there are some patients who derive less benefit and might derive some risk from the prolonged antiplatelet therapy. Still, the rates of adverse cardiovascular events, I think, have plateaued at this low level. So what can we do to go forward? The technological innovation certainly has improved outcomes over the past 20 years, but I think the real challenges are in identifying the appropriateness of the scope of what we treat. Not everything that we can treat should be treated, even though technically we've become much better at getting good results. And so we treat a much broader group of patients. There's no doubt that primary PCI has improved mortality rates after myocardial infarction, but I think that there are challenges within the treatment of multivessel disease and complex lesions. And we really need to not just go with our personal clinical experience, which obviously guides the way that we study clinical cardiology, but hold the data that we acquire to a very high standard, requiring randomized trials in many cases, but also high-quality observational data analysis to guide our strategy and implementation. So if we look at the history of coronary stenting, and really start from the bare metal stent to drug-eluting stent transition that was made, it's true that an incredible advance was made by the introduction of drug-eluting stents. But although Dr. Braunwald, in the review article that was just mentioned in the last speaker's talk, did point out the development of drug-eluting stents, we have not decreased mortality. We've only improved the effectiveness of lesion-based treatment. And so the risks of restenosis have reduced significantly, 75% approximately. But the real challenge going forward is to reduce more important cardiovascular events like myocardial infarction. We were able to take the randomized trials that looked at the efficacy and pool together data around the time that there was such a high controversy about drug-eluting stent safety, and really found that within the randomized trials that there was not a significant difference in stent thrombosis, although the greatest caveat being that these studies were, number one, underpowered with a small number of patients, even when you pool together all of this data available, and number two, conducted in relatively low-risk patients, primarily with single-vessel treatment. After that, there's been a multitude of observational studies, and the real challenge, I think, with observational data has been the relative inconsistency of the findings across studies. It leads to a concern on the part of clinicians that, well, we don't know what to believe from observational data analysis. I would argue that you can tell by reading the methods first of an observational study whether the data are going to be reliable. And just looking at one simple metric, one can see that the quality of follow-up is a critical determinant of observational data analysis. And whereas results from the very first publications from Sweden had relatively low follow-up, results from multiple other countries showed consistent and high degrees of follow-up that really helped guide our understanding of safety. So this was true in a study performed in Canada, which was one of the large prospective cohort studies that used propensity scoring to compare patients with drug-eluting and bare metal stents, and showed no increase in mortality associated with the drug-eluting stents. And we showed similar findings to that in the data from Massachusetts, where there's a mandatory reporting of all outcomes following PCI. It's important then also that to look at observational studies as a way sometimes to gain information more quickly than we can obtain in randomized trials. So we were concerned about the safety in patients with acute myocardial infarction even before there had been any large randomized studies completed. This was quite helpful in excluding a risk because by the time that drug-eluting stents were released, they were being used very broadly, and it was important in our highest risk patients to determine whether there was a significant risk. And we did find that there was no increase in mortality associated with drug-eluting stents, even though there were theoretical concerns at the time. And this was followed by the very important validation from a randomized clinical trial in the Horizon study. So what about, I've been talking so far about really older drug-eluting stents and the studies that have presented so far. And we know that those stents are no longer used in clinical practice, either the original sirolimus-eluting or the original paclitaxel-eluting stents. What have we learned that can guide the development of new technology? Well, unfortunately, what we've learned is that we really do need large clinical studies to still determine the safety of stents. We have good surrogate endpoints for the effectiveness, things like looking at angiographic measures that we've studied very carefully, even in the bare metal stent era, can be very helpful to quickly determine the efficacy of a stent. But as with drugs, stents may have rare adverse events that we really need to understand with large trials. And the unfortunate thing is that we don't have good ways of predicting that. And I think this is a caution going forward because although there might have been one scare in the past with drug-eluting stents that's abated now, as we introduce new technology, some of which I'll discuss later in the talk, we need to hold it to the same high standard. We cannot presume that because we have an exciting new method of treating a coronary artery, that we don't need to hold it at least to the same standard that we have in the past. So going forward, the optimal constituents of stents are really not well understood based on the preclinical data and require clinical outcomes. So what are the newer stents? Even some of the stents that I'll discuss now are being used a little bit less. The Endeavor stent has an excellent safety profile as measured in randomized trials. But the ultimate validation is still forthcoming. It takes a long time to run large trials that are really powered to make head-to-head comparisons on things like stent thrombosis. So the PROTECT study is a study originating out of a European investigators' initiative to compare two different drug-eluting stents. And while these stents, in fact, the sirolimus-eluting stent is no longer available for broad use, they are implanted in many patients, but more importantly, this trial has the potential to identify the concept that different constituents of stents might have an impact on safety. And these results we expect will be presented at ESC this summer. Other stents that are commonly used or related to those that are available now have also compared safety, but haven't had head-to-head comparisons to look at the duration of antiplatelet therapy, for instance. So while there may be observational studies that show early discontinuation to be safe for the current stents, this is another concern, I think, that we need to raise broadly for all stents, because it's not simply a lesion-based issue, but a more general issue of prevention of progression of cardiovascular disease events. So the iterations that we've had in technology up until now have been important, I think, for the practical use of stents. We've seen modifications to polymer, so we have a better understanding of the kinetics required for better efficacy. Namely, there's been great progress with zotorolimus-eluting stents now using a more durable, a longer release polymer with the Resolute drug-eluting stent that's now commonly available. And there have been thinner stent struts that have been employed, and we can now have both thin stent struts and good radial strength, so that allows us to deliver stents to very complex lesions, and also to be able to see the stents better with new alloys that are being used. In addition, there are platforms that are being developed and that will look at different kinds of polymers that change the paradigm. We have concerns that even though the stent thrombosis rates are difficult to distinguish between drug-eluting and bare metal stents, and even different drug-eluting stents, that it may be the polymer and the existence of a polymer that lasts an entire lifetime that might mediate some ongoing risk of thrombosis or endothelial dysfunction leading to thrombosis. And so there is a great push to look at bioabsorbable polymers going forward. And this is one example of an everolimus-eluting stent on a platform using a platinum chromium backbone, where there is a durable polymer being compared to a bioabsorbable polymer. And this is the Synergy stent that has been tested and is now has had 1 year of follow-up about to be presented EuroPCR. But if one looks at the data that were presented in the JACC publication, this has had very similar efficacy, but the question really going forward is, does this actually improve clinical outcomes? And so far, the studies are not powered to do so, but the idea is that the polymer may be able to be resorbed within the first 3 to 4 months after the stent has been implanted. And this has obvious implications for the safety of stents going forward. So I'm excited because we may be able to not only modify the stent, but also the associated treatment strategy that goes with it if we can reduce the duration of antiplatelet therapy. But I think that without randomized trials to show that this is safe, we cannot presume that it will be. So other interventions and development of new device technology that will take this model even further are the use of completely bioabsorbable stents. And the one that is furthest along in terms of development is developed by Abbott. And this is a completely bioabsorbable polyl-lactide everolimus-eluting stent. So it's not enough just to have bioabsorbability, but one also needs to have a drug to prevent the early reaction of the vessel wall to injury. But with this combination, there is a great hope that we won't, in fact, have to coat the arteries with metal, but have a stent that is resorbed. I think that there are still technical challenges going forward. One of the interesting things is that the time that it takes for the stent to be fully bioabsorbed is over 2 years, and therefore I don't think that we can assume that these stents are going to be more safe in the short term, or necessarily pretend a shorter duration of antiplatelet therapy that would be required going forward. And so I think this is an important characteristic as the studies are being designed to look at the long-term safety, to think about the mechanical and biological properties of the stent over time, not just during the acute implantation. So far, the data out to 2 years are relatively limited and in small sample sizes. And so it's difficult to determine whether this is the same, better, or different from what we would expect from a standard drug-eluting stent of the current generation. Also, even acutely, we have concerns about the development of the technology, in that we expect from even bare metal stents, but good drug-eluting stents, that the acute procedural result is going to be excellent. And that means obtaining a large lumen in order to prevent problems going into the future. The size of the lumen is a determinant not only of restenosis, but also of stent thrombosis rates. And so we have to watch very closely the acute results. For stents that are conventional with a metal backbone, we expect a residual stenosis, a diameter stenosis post-procedure of on the order of 5%. And so the question will be, will the benefits of the theoretical benefits of a completely bioabsorbable stent overcome this incomplete treatment of the vessel acutely, even though the 20% diameter stenosis may be sufficient for acute flow down the vessel. This has been an occasion to really find benefit for using some of the advanced imaging modalities. One can see in the panels here on the left OCT, or optical coherence tomography imaging, in the center grayscale IVUS, and on the right so-called virtual histology IVUS, which uses color to demonstrate the different constituents of the vessel wall. And I think that it's very helpful to have these more refined imaging techniques to see when is the stent resorbed and what are the characteristics of the vascular lumen. And I think we're early on, but these imaging technique development is very synergistic with the development of the new technology. But one can see that even at 12 months, there is the presence of stent struts, and so this is not a stent that vanishes over the near term. In terms of treatment strategy going forward, I think there are many important questions that we have to answer, but a couple that are really at the forefront are antiplatelet therapy and multivessel PCI. So I'll first talk to you about antiplatelet therapy, which is something that we've invested a lot of effort into worldwide, really, over the past few years, and we hope to get answers for in the near future. So we know that there's broad variation in practice. I can say that even within the United States, from center to center, our practice differs widely. If you poll American interventional cardiologists, a few years ago, I would say that about 50-50 patients were being continued on antiplatelet therapy beyond 1 year versus not. And that percentage changes according to practice location, and it changes from year to year. And that's really in the absence of hard clinical data, because most of the data that we've had to date has been observational. I will go through some recent randomized trial results. This was seen in the results from an important TIMI trial, which was designed to compare prasugrel versus clopidogrel, but also looked in a registry after the treatment was completed about how long patients continued on therapy. And you can see that while in North America there was about a 50-50 chance, as I mentioned, of continuing beyond 12 months, that worldwide the practice, although it looks uniform here, was relatively low in terms of the utilization of drugs beyond 12 months. We found in a more recent study of the pooled trials of a drug-eluting stent, this is from the Resolute Zotarolamus-eluting stent clinical program, because it was conducted worldwide, we were able to look at the practice in multiple different countries, and I presented these data at the ACC meeting. But I think it's quite interesting to see how the different practices vary, and even within what we think are regions that might have similar either insurance programs or considerations for economic providence of drugs, there is still considerable country-to-country variation, and I would imagine that even within countries there may be variation in practice. I called out the results from Spain specifically here, and it's kind of interesting. Actually, the results that we saw from Spain, granted in a clinical trial program and not in real-world use, mimic what we see in the United States, and so there's still a relatively high utilization of antiplatelet therapy beyond 12 months of about 60%. So why is there so much variation? There's so much variation in practice because we don't know what the answer is. And that is a cause, I think, of potential differences in clinical outcomes that can be prevented, but also differences in costs that might also be prevented. So I think it is an important question to study. And the FDA, coming out of the 2006 panel meeting looking at the safety of drug-eluting stents, raised this concern, and it was finally in 2008 that a trial was started in the United States. And this is a large study. We completed enrollment of over 26,000 patients that I, together with the co-investigator Dean Kariakis, have been leading, but has really been a worldwide effort. And this study has randomized patients to 12 versus 30 months of dual antiplatelet therapy, presuming that they don't have any contraindications at 12 months. So the primary analysis is of drug-eluting stent-treated subjects, will be the vast majority of patients who have been enrolled. There's also a secondary analysis because we still don't have great data comparing bare metal to drug-eluting stents in undergoing similar antiplatelet therapy regimens. And it's possible that if the results of the study show a benefit for longer antiplatelet therapy, that it could be something like prevention of cardiovascular events and not simply stent thrombosis. So we're very interested to see the results of a bare metal stent comparison as well. Because the potential benefits may not just be lesion-based, but may be more global cardiovascular risk reduction, the study is powered not just to look at stent thrombosis reduction, but also to look at the prevention of death, myocardial infarction, and stroke. And importantly, we know that there's a downside to longer therapy. It will certainly increase bleeding risk, and the question is, will this be significant? And that is why there's a powered safety endpoint as well. So the study has enrolls worldwide and has had good representation from Europe as well as Australia and New Zealand. And we completed enrollment beyond what we initially targeted to reach 26,000 patients in July of 2011. And so we know now that the follow-up will be completed in 2014. I presented analysis of the baseline characteristics of patients last year at TCT, and I think this is relevant because we really intend this study to be very broad and as generalizable as possible. So we've enrolled patients with many complex features. They may have left main treatment, they may have bifurcation stenting, they may have acute coronary syndromes, and there's a very high representation of approximately half of the patients having some measure of lesion or anatomic complexity. The distribution of thienopyridine type is distributed well between the different drugs that were available at the time of enrollment. In the United States, we had prasugrel and clopidogrel, and we have a good representation of both drugs, and so I think it will be generalizable to different drugs as well as different patient types. And similarly for stent type, the vast majority are stents that are still being used in clinical practice, but there's good representation of a variety of different types of drug-eluting stents. And it will be important to look at whether the results are consistent across drugs and stents as well as patient groups. But there have been data since we started this trial and even since we completed enrollment from other studies. So I'd like to walk through the implications of some of the international studies that have been published. And two of the most important ones are probably the study out of Korea by Dr. Park et al., which was a post hoc combination of two studies that were stopped early because of practical concerns, not because of safety concerns. And this study was presented in the New England Journal, but showed no difference in adverse cardiovascular events when comparing a longer duration of therapy to a shorter duration. Some of the challenges are the incompleteness of follow-up and really lack of power, because the kind of sample sizes that we're talking about in each of these studies is on the order of 1,500 to 2,000 patients. And so not powered to look at stent thrombosis rates, and probably not powered to look at significant or clinically meaningful differences in the rate of myocardial infarction either. So it doesn't provide me significant reassurance of the safety of shorter duration of therapy. The other challenge with this study was that the time point of randomization was highly variable. The Prodigy study was published recently in Circulation and had a similar sample size, a higher degree of follow-up, and I think is an important study because it was conducted with a high degree of follow-up, and so had certainly good quality from that perspective. There was no significant difference in the primary clinical endpoint. That being said, again, relatively low power compared to a study that could be done in the 10,000 plus patient level. And so not power to look at stent thrombosis. So although there was no difference in stent thrombosis rates, that's not particularly meaningful when there's a lack of power. Now, there was a difference in bleeding, and I think that this is not surprising, particularly when we talk about an endpoint that's more inclusive. So the investigators took an endpoint that during the course of the study was proposed by the Academic Research Consortium, a consortium working together with the FDA and academics to propose a standardized definition for trials. And I think it's incredibly important to have standardized definitions across studies. That being said, this is a fairly sensitive endpoint. So type 2 bleeding is not the same thing as gusto, moderate or severe bleeding. It can include patients who didn't have a hemoglobin drop or didn't require any treatment for their bleeding. So while this may be an important factor for patients, one cannot say that it has the same importance as stent thrombosis, for example. So there are limitations to the studies that we have completed to date, and so I think that these studies still highlight that there's a remaining question about the balance of risk and benefit, as well as the implications to the cost of providing these treatments. So I'm going to move on next to another important area, I think, that has been really alluded to by many of the speakers in this conference, which is we need to rethink how we treat multivessel disease. And I think that the results of a study like FAME, which I don't need to reiterate here, have really been incompletely implemented. Particularly, I can speak for the United States. FFR is being performed in less than 10% of coronary interventions, and I think that we need to think about it much more often than that in order to prevent unnecessary lesion treatment, which is associated with significant risk. I think this also sets us up for a different understanding of how to optimally treat patients with stable angina. What was performed in the COURAGE trial to treat patients with PCI was probably an old standard. And while I don't think that treatment of stable lesions is going to translate to prevention of myocardial infarction, we've seen that hypothesis tested and failed over many years, even in the angioplasty era with the ACME trial. I think that there are better ways to relieve angina that may be associated with less risk. And the FAME2 trial, I think, is set up to demonstrate that. So I think we look forward to seeing the results of this study where patients really had treatment guided by the FFR and were only randomized into the trial if they had a significant stenosis by FFR. And as you know, this study was stopped early by the DSMB because of a positive finding. Again, there will, I expect, be a tension between the different kinds of endpoints in the trial. It's practical to design a trial with a composite endpoint that includes death, MI, and repeat procedures or repeat hospitalizations. However, those don't all have the same rank and importance. And so I think for the interpretation of the trial, we'll have to look carefully at the balance between the two. And understanding those components gives us the best mechanism to better inform patients about what the risks are that they can expect from the choices that they have in front of them. And I think the choices that are in front of patients are becoming more complex, but we are getting better and better data to understand them. I know that Dr. Dion will speak to the syntax trial results in more detail, so I won't go into detail here, but I think it is important to break up the components of a composite endpoint to really be able to have an informed discussion about the risks of repeat revascularization separately from the risks of acute safety. The late follow-up, I think, is critically important in a trial where we're presuming to treat patients over their lifetime following revascularization. And so we need to understand how often they return for procedures so that we can explain that to them, but also what is the prolonged benefit of a regional approach like bypass surgery that can treat a whole region of the coronary artery versus a lesion-based approach. So how to understand this comparison going forward? I think that there are many things that are changing in the practice of PCI and bypass surgery. For PCI, and probably also for bypass, I think that we can do much better with guidance to understand which lesions can be treated, and so that both treatment strategies will improve and will need to be compared again in the future. The balance in the endpoints is something to carefully consider as we go forward in clinical practice, and really to do an even better job of incorporating not just cost, but the patient concerns about quality of life, and also decision-making so that patients can be incorporated into decisions about treatment strategy. So to conclude, I think innovation in PCI has benefited tremendously from the development of new devices and new drugs and incredible progress. And so we're grateful that we've been able to practice in this environment where over the past 20 years there have been incredible strides in both the safety and the effectiveness of our treatments. But I think that we have to hold ourselves to an even higher standard going forward of requiring evidence that is more inclusive of the breadth of patients that we treat in clinical practice and also incorporates information that will allow patients to make better decisions for their own care. Thank you.